Thank you for joining us today to our talk entitled Sickle Cell Lung Disease in the COVID-19 Era by Elizabeth Klings. This talk is sponsored by the ATS Sickle Cell Lung Disease Interest Group, ATS more broadly, and the local chapter of the Metropolitan DC Thoracic Society. Dr. Elizabeth Klings is an associate professor of medicine, director of the Pulmonary Hypertension Center and the Center for Excellence in Sickle Cell Disease, caring for over 500 adult and pediatric patients at Boston University School of Medicine. She received her BA and MDs from New York University and completed her training in internal medicine, pulmonary, and critical care at Boston University. She led the American Thoracic Society sponsored clinical guidelines for the diagnosis and treatment of PH and sickle cell disease, and the workshop for defining clinical and research priorities in sickle cell lung disease more recently. Her current research interests include the roles of sleep disordered breathing and venous thromboembolism in PH and of sickle cell. She's a member of the Medical and Research Advisory Council of the Sickle Cell Disease Association of America's International Task Force on COVID-19 that meets weekly to update recommendations for patients with sickle cell disease infected with COVID-19. So welcome, Liz. We look forward to your talk.
Thanks a lot, Parker. I wanted to start by talking a little bit about a patient of mine who we cared for at Boston Medical Center with COVID-19 in addition to sickle cell disease. This is a 39-year-old male with a history of hemoglobin SC disease, a prior pulmonary embolism, morbid obesity with a BMI of 40, who was originally admitted to Boston Medical Center from March 22nd to the 24th for myalgias and fever. He was diagnosed as being SARS-CoV-2 positive at that time, but really had no respiratory symptoms at all. He was on room air without any hypoxia or dyspnea, and his chest x-ray was negative. He was discharged home and did well for about 4 to 5 days, but was readmitted 6 days after his discharge for worsening dyspnea and pleuritic chest and back pain. His vital signs at admission included a temperature of 99.8 degrees Fahrenheit, heart rate of 110, blood pressure of 100/60, and an oxygen saturation of 84% on room air. That increased to 94% on 4 liters. His chest exam revealed scattered crackles through both lung fields with decreased breath sounds at the bases. He went for a CTPA-gram on admission, which did not reveal a pulmonary embolism, but did reveal infiltrates in both lungs. Here you can see a left upper lobe infiltrate peripherally, as well as left lower and right lower lobe infiltrates on this CTPA-gram. A Quinton catheter was placed overnight, and then his chest x-ray the next morning, in addition to showing the Quinton catheter in his right internal jugular vein, now demonstrated left upper lobe, lower lobe, and right middle and likely lower lobe infiltrates. His diagnosis is acute chest syndrome due to COVID-19. So what we know about acute chest syndrome and viral viruses really dates back to the cooperative study on sickle cell disease, which was a prospective study across 23 centers conducted between 1978 and 1998 in the United States. A review of 671 episodes of acute chest syndrome collected during those 20 years revealed that multiple viruses, although not coronavirus, but multiple other viruses, were identified as an etiology of acute chest syndrome in these patients, most notably influenza. We've come to understand over the last 20 years that influenza in patients with sickle cell disease increases both the risk for hospitalization as well as the risk for acute chest syndrome. J.J. Strauss, when he was at Johns Hopkins, did a retrospective chart review of patients who were infected with influenza, and he looked at 123 patients with sickle cell disease, 94 of whom were infected with either influenza A or B, and 29 who were infected with H1N1. It was shown at that time that those infected with H1N1 had an increased rate of acute chest syndrome, as well as an increased need for an intensive care unit admission and mechanical ventilation. This was very concerning to those of us in the sickle cell community that patients with sickle cell disease, if they were to become infected with COVID-19, could be at increased risk for severe acute chest syndrome. How we define severe acute chest syndrome is the need for greater than 50% FiO2 or the need for intubation. And then why we try to subclassify these patients into mild, moderate, or severe is really because of the risk of multi-organ system failure and rapidly progressive acute chest syndrome in some of these patients. We know from the literature that patients with sickle cell disease who have known history of pulmonary hypertension or who present with multilobar disease or thrombocytopenia are those who are at the most risk or the highest risk for rapidly progressive ACS. The only study to look specifically at this population was a retrospective chart review of 173 patients, both adult and pediatrics, who were admitted with acute chest syndrome but rapidly progressed to respiratory failure within 24 hours of admission. What they were able to identify in the adults was that those who had rapidly progressive acute chest syndrome had a higher incidence or higher rate of acute kidney injury, hepatic dysfunction, change in mental status, and death. But in looking at predictive factors for rapidly progressive ACS, their multivariate analysis found that only thrombocytopenia was the only predictor of rapidly progressive ACS, increasing with approximately a 5-fold increase in the development of acute chest syndrome, rapidly progressive ACS. It is thought that in some cases of rapidly progressive ACS, this is due to what's called fat embolized syndrome. This is a rare complication of sickle cell disease that's thought to be related to the breakdown of fat within the pulmonary vasculature, leading to the release of free fatty acids, leading to severe sepsis, acute lung injury, pulmonary edema, and hypoalbuminemia. It is unclear exactly how this occurs, but there is some concept that this may relate to the bony infarction of the long bones in the legs, particularly the femur, as a trigger for both bone marrow and fat emboli. Fat emboli syndrome seems to be more common in those with higher hemoglobin concentrations, such as what is observed in hemoglobin SC disease. So actually having hemoglobin SC may put you at higher risk. And there is a classic triad, which of a petechial rash, change in mental status or CNS depression, and pulmonary edema that is observed. But you don't need all three parts of the triad to be present. And as you would guess, thrombocytopenia, because of its association with rapidly progressive ACS, does occur in fat emboli syndrome as well. But also you can look for worsening anemia and hemolysis. And if you were to do a bronchoalveolar lavage, you could find fat-laden macrophages, although many times we do not perform BAL in these patients. Clinically, what is seen most commonly is pain, but also neurologic impairment and respiratory failure. So now that we've been involved in the COVID-19 pandemic for several months at this point, we have been able to gather clinical cases both from experience as well as the published literature. To date, there have been 7 cases published of patients with sickle cell disease infected with COVID-19. There were 3 individual case reports of acute chest syndrome, 1 each from France, the Netherlands, and the United States. The United States case was from Mount Sinai Hospital in New York City. The case from France highlighted the use of tocilizumab in one of these patients, and this is the case that I'm presenting here, mainly because it was the only case report that was associated with the CT scan findings of this patient. This was a 45-year-old male with hemoglobin SS disease who also has a prior history of pulmonary embolism, who developed acute chest syndrome due to COVID-19. He had fever as well as acute hypoxic respiratory failure not requiring intubation, but requiring high levels of oxygen supplementation, 15 liters of oxygen with 100% FiO2. His laboratories of note included a hemoglobin of 7 grams per deciliter, lymphopenia, an elevated CRP at 189, and an elevated ferritin at 3271. He was treated over the course of his hospitalization with antibiotics, transfusion, hydroxychloroquine, and tocilizumab with improvement. This is what was submitted as his CAT scan findings. And what you can see here are ground glass infiltrates. They are highlighted by the arrows throughout both lungs, with a predominance of the middle and lower lobe on the right, as well as the left lower lobe. And there is an occasional air bronchogram that you can see within these infiltrates. The other cases in the literature was a case series of 4 adults from University of Illinois at Chicago who were admitted with COVID-19. 3 of these 4 patients had very mild or no pulmonary symptoms. 1 was treated with antibiotics for ACS. There was 1 case out of the 4 who developed acute respiratory failure requiring intubation and mechanical ventilation, and that patient was treated with antibiotics and exchanged transfusion. Julie Panapinto at Medical College of Wisconsin really wanted to try to get a better sense of what was happening clinically with patients with sickle cell disease infected by COVID-19, and established a multicenter registry that sites across the United States are contributing patient data to. And I wanted to share with you the most updated version of these data that were compiled on Tuesday, April 28th, 2020. Just to give you an idea of where these cases are being submitted from, as you would guess, the sites with the greatest level of submission are also the sites in the United States where COVID-19 is most prevalent, most notably in New York State and Massachusetts, which have amongst the highest rates of COVID-19 infection. Currently, we have 110 cases within the registry, predominantly, and this is across the lifespan, although the average age is almost 32 years, and this is very heavily weighted towards adults. The population is about 60% female, and as you would guess, predominantly African American. About 68% of the patients have hemoglobin SS disease, but as is common in most sickle cell centers, approximately 30% of patients have another hemoglobin genotype, most commonly hemoglobin SC disease, affecting approximately 22% of these patients. Approximately 57% of the patients were on hydroxyurea, with smaller percentages being treated with some of the newer agents for sickle cell disease, including crizolizumab, L-glutamine, and voxelotor. And on average, this is a population with where almost 30% of patients have had a prior episode of acute chest syndrome, and approximately 60 to 70% have had previous visits to either the emergency department and or the hospital for vaso-occlusive crises. These patients, approximately 10 to 20% of these patients had evidence of chronic end organ damage, including pulmonary hypertension, but also a history of renal disease, including albuminuria, and CNS disease, particularly a history of overt strokes. Interestingly, we are seeing an increased association between vaso-occlusive crises and COVID-19 infection. And in the registry, 60% of patients presenting to an emergency department or the hospital that were diagnosed with COVID-19 had symptoms of increased pain. The second most common group of symptoms seen in 29% related to the presence of pneumonia. So fever, shortness of breath, cough. The majority of these patients, 70%, required hospitalization. However, almost 12% of patients did not need to be seen in either an emergency room or hospitalized. And only a very small fraction, 11%, required the intensive care unit. Almost 43% required a transfusion of any type. 76% of those patients developed received a simple transfusion, and 23% received exchange transfusion. For those patients who were hospitalized, their average length of stay was about 7.5 days. So as you can see from the pie chart on the upper left, there was a spectrum of disease severity ranging from asymptomatic in very few patients. I think this might have been actually one patient. But the majority of those with sickle cell disease with COVID-19 actually had mild disease. Only 17% had severe disease, and 7% were defined as having critical disease. Despite that, we have seen an increased frequency of death compared with the general population. There were 12 deaths out of 110 patients in the registries thus far, accounting for a mortality rate of 10.9%. 6 of the patients within the registry developed renal failure, although several of those had pre-existing chronic kidney disease. So getting back to my patient underwent an exchange transfusion of 6 units of packed red blood cells. He also received tocilizumab as part of the protocol at Boston Medical Center that was being followed at the time, in addition to antibiotic treatment for acute chest syndrome with ceftriaxone and azithromycin. His chest x-ray, as well as his hypoxia, improved rapidly over the next 48 hours. And he went from requiring 5 liters of nasal cannula to room air, and he was discharged to home 3 days post-exchange transfusion and has done well since then. So what can we say about the management of sickle cell disease patients in the COVID-19 era? Well, there's been an international group of 32 experts that has been assembled by the Sickle Cell Disease Association of America that has developed and updated a document to try to highlight how to best manage these patients on both the inpatient and the outpatient basis. You can find the results of our weekly report on the American Society of Hematology website, www.hematology.org. And I'm going to review some of our recommendations for you right now. A lot of our focus has really been on how we can keep our sickle cell disease patients safe from the coronavirus, and many centers, including ours, have switched the large majority, if not all of our patients, to telehealth visits for their routine outpatient care. We also stress the need to continue all outpatient medications when patients are admitted to the hospital, as well as when they are at home. Because of the data that is coming out of our registry, we are recommending the consideration of COVID-19 testing for all patients with sickle cell disease presenting with a vaso-occlusive crisis, and are recommending an assessment for acute chest syndrome in all patients who are COVID suspect or diagnosed with the disease. We are recommending a chest x-ray on admission, or if the patient is going to be discharged from the emergency department, a chest x-ray prior to discharge. And you can consider repeating a chest x-ray in 2 to 3 days in patients who are COVID positive, because we know that this is the most frequent time to observe acute chest syndrome in patients with sickle cell disease. All patients who have an infiltrate on their chest X-ray, and symptoms, this is consistent with acute chest syndrome. And there needs to be aggressive treatment for acute chest syndrome, including antibiotics to cover the encapsulated organisms as well as the atypicals, the use of transfusion, as well as close monitoring, and particularly keeping an eye out for thrombocytopenia. For patients who have acute chest syndrome and hypoxia, we are advocating for simple early exchange transfusion. Because of concerns of blood shortages, and because the certain centers may not have the ability to do exchange transfusion, for patients who have a hemoglobin of less than 9 grams per deciliter, you can consider simple transfusion as an initial first step. But for those patients with hypoxic respiratory failure, exchange transfusion is the treatment of choice. We recommend DVT prophylaxis for all admitted patients. Because of the growing body of knowledge concerning the risk of hypercoagulability in patients infected with COVID-19, we do want you to consider evaluating your patients for venous thromboembolism, and particularly think about this in patients who have markedly elevated D-dimers and or clinical symptoms. One thing to point out is that patients with sickle cell disease who present with acute chest syndrome can have transient elevations of their pulmonary artery pressures by echo. In patients who have known pulmonary hypertension, this can precipitate right-sided congestive heart failure, and this is something that physicians need to be aware of and be on the lookout for. There may be a role for the inhaled pulmonary vasodilators, including nitric oxide and epoprostenol in this setting. But you also need to balance this with the fact that in patients who have pulmonary hypertension related to sickle cell disease, we know that 60% of those patients have some degree of left-sided heart disease. And this can be worsened with the use of pulmonary vasodilators. We understand that pediatric patients with sickle cell disease have an increased frequency of asthma. We need to consider treating asthma in those pediatric patients who present with acute chest syndrome. So in summary, our understanding of the interaction between COVID-19 and sickle cell disease remains limited. But what we are encouraged by is that for many patients with sickle cell disease, COVID-19 does not necessarily present with severe disease. And there are some patients, particularly in the pediatric age group, but also some young adults who may have mild disease that may not even require hospitalization. Similar to other populations, the disease is more severe in adults, and from our mortality data, the mortality risk does seem to be higher in patients with sickle cell disease, but it also seems to be more skewed towards those who have significant end organ disease. And this may represent the subgroup of patients with sickle cell disease who are at the highest risk for death. Severe disease from COVID is not isolated to just those who have hemoglobin SS disease, and so you need to think about it as well in your patients with hemoglobin SC disease. And while there's a lot of interest in experimental therapies, we really don't know what the role of these therapies are for treating patients with sickle cell disease. And because of this, we refrain from making any specific recommendations in this regard. I'd like to thank you for having me present what we know about sickle cell disease and COVID-19. I'd like to take some questions that were submitted to Parker from several of the members of the sickle cell lung disease interest group. Thanks.
Great, thank you so much, Liz. So we did receive questions from across the US and internationally as well. I'll start off with a question that came from Carol Rosen from Cleveland Rainbow Babies and Children's Hospital. And she wanted to ask about, what do you think are the contributions of underlying pulmonary disease for risk factors for severity of COVID versus also the social determinants of health? So We know our sickle cell patient population has to deal with a lot of psychosocial and economic challenges, and how does that play a role in their care?
Thanks, Parker. That's a pretty complicated question. I think as we are starting to understand, the African American community seems to be at increased risk from COVID-19 pretty much across the board, and complications related to COVID-19. We do not specifically understand how the social determinants of health play a role in the disease severity of COVID-19 amongst sickle cell patients. However, I will say that by doing many of our telehealth visits that we have been doing for our outpatients, we have addressed some of the issues related to transportation that prevent our patients from coming for routine clinic visits. Many of our sickle cell patients are paranoid about leaving the house, honestly,
Right.
and are avoiding coming to acute care facilities for management of vaso-occlusive crisis and the like. And so I would be concerned that there may be some delay in seeking care.
Certainly, as we see in other populations.
Yes.
Yeah.
And, in terms of the impact of underlying lung disease, I think where we are seeing this more is in the adults, and several of our patients who have died have had significant underlying lung disease, either restrictive lung disease with pulmonary fibrosis or with fibrotic changes on their CT scan, or pulmonary hypertension underlying their presentation. But I would say it's too early to know the true impact of underlying lung disease on this presentation.
Yeah, that makes sense. Another question we had from Christy Sadramelli at Johns Hopkins was just that. Are there particular pulmonary phenotypes that seem to be presenting more frequently, or is there any increased risk with someone that has pulmonary hypertension versus asthma? But I would guess we're probably still too early in collecting that registry data to know.
Yes, I would agree with that. It is still too early to really understand this completely. What some of the larger volume sites are seeing, though, is that in some patients, there may be a predominance of pain symptoms at presentation, but the patients who seem to have more severe disease will present with dyspnea and more of the classic COVID-19 symptoms. But I also think that it's too early to really hang your hat on that.
Right. So one question that we received from Courtney Fitzhugh in NHLBI in Bethesda was the type of patient that you're not quite sure how aggressive to be. So if you think that someone, for example, they seem to be developing signs and symptoms of ACS, they have an infiltrate, they have COVID, but they're not hypoxic, they don't have maybe other symptoms, how do you decide, as you walk through some of the management recommendations, how do you decide when to pull the trigger for exchange transfusion, for example? Will you be more conservative with someone in COVID-19?
That's a good question, and we really don't know exactly what the exact approach should be. For patients who are not hypoxic, they probably do not need to undergo exchange transfusion. And I think what we're learning from the registry data is that not everybody who gets admitted receives a transfusion, and most of them are doing fine. We would recommend standard treatment for acute chest syndrome, including antibiotics, to cover the possibility of an atypical or bacterial superinfection, something that we're seeing commonly in COVID without sickle cell disease as well. But I think we're recommending the use of antibiotics and consideration of transfusion, particularly if the patient is hypoxic.
That makes sense. That's great. Another question that we received from Jennifer Knight-Madden at the University of West Indies in Jamaica is how do we, especially in a resource poor setting, how do physicians have to think about the flow of a sickle cell patient with COVID through the hospital system? So many patients with sickle cell disease, if they initially present and are a person under investigation for COVID, they'll end up being cohorted with other people who are at high risk for COVID. And, do you have any thoughts or stories to relay on how Boston University is working through the PUIs and knowing that if a patient with sickle cell disease presents to a hospital, they're likely going to have to get tested for COVID, which you alluded to, that you should have a low threshold for testing for COVID.
Yes, and so at Boston University and Boston Medical Center, which is our primary teaching institution, we are cohorting our COVID suspects separately from the rest of the hospital. And, one of the big challenges in managing this disease, as many of you know, has been the testing, the relative lack of testing, the amount of time that it takes to get the results of the testing. And that has been consistently improving, but still remains subpar on many levels. And I think that we've approached this is we've started testing all of our patients in the emergency department who present with vaso-occlusive crisis. It means that our sickle cell patients who are then who then get admitted for vaso-occlusive crisis are getting admitted to the COVID floors until we know that they are COVID negative. But I think we are more concerned that we are going to miss COVID in a COVID presentation.
Right. Again, having that low threshold.
By being so focused on the vaso-occlusive crisis.
Right. So one thing that we know that comes with vaso-occlusive crises is inflammation. So sickle cell disease is an inflammatory disease, and Guindo Aldioma from the Sickle Cell Center of Excellence in Bamako, Mali, had a question about the role of inflammation in COVID-19 and if there might be an opportunity to use steroids, knowing that there's different considerations of when to use steroids in sickle cell disease than other patients.
So the topic of steroids as an anti-inflammatory in COVID-19 is one that's gotten a lot of attention, as well as is definitely controversial without sickle cell disease being involved in it. We know that COVID-19 induces a pro-inflammatory state, and just by itself. And so, what I can say is that that's promoted a lot of the interest in steroids in non-sickle cell disease patients infected with COVID. I think the jury is still out as to whether or not steroids are beneficial in the treatment of COVID-19. And I think that when you think about that in the context of sickle cell disease, it becomes even more dicier. We know that the use of systemic steroids in patients with sickle cell disease may increase the risk of rebound vaso-occlusive crises in patients. However, we also know that steroids for a known condition such as asthma are beneficial. And so what I would say is that based on what we know right now, I would consider the use of steroids for patients who are known to be asthmatic and who are having, and this is where we see this most, is
a specific indication for the steroid.
Yes. Exactly. The pediatric population with sickle cell disease, if they are presenting with COVID and are increasingly short of breath with wheezing, yes, I think they should be treated with systemic steroids. But no, I do not think that there's an indication for using steroids across the board in this population.
Okay. So another problem that comes with the inflammatory state is hypercoagulability in sickle cell disease. And, more recently, we've been learning about the increased risk for DVT, pulmonary embolism, and the prolonged risk of recurrent events. So we've also heard about hypercoagulability in COVID-19. So can you talk a little bit about how you might have either do you have a higher suspicion for clot in your patients presenting if they're COVID-19 positive, or would you be more likely to start empiric anticoagulation? How has that played into care decisions you make?
That's a really great question, and I think
that comes from Benjamin Kopp.
Yeah. Well, thanks, Ben. I think that's a really great question, and the short answer is we don't know. But what we do know is that by the age of 40, 11 to 12% of patients with sickle cell disease will have experienced a venous thromboembolism, and that the rate of recurrence is somewhere between 31 and 36%. So this is a hypercoagulable state at baseline. We are also beginning to understand that COVID-19 is in some patients at least a hypercoagulable state as well. How these two hypercoagulable states interact is really unclear. But I think there's been a growing appreciation for the fact that patients who are infected with COVID-19 are maybe at increased risk for venous thromboembolism, as well as arterial thromboses. And I think that in a patient who has an underlying hypercoagulability, you need to be more vigilant in your assessment for venous thromboembolism. And whether you base this on a certain cutoff level of a D-dimer level or clinical symptomatology is really going to be based on the experience of your institution and what is, I think the protocols that are being developed by individualized institutions as well as one's own clinical experience. But I do think that, the Sickle Cell Disease Association group did not want to make specific recommendations for patients with sickle cell disease, but we are really trying to follow what is being recommended by the thrombosis experts in both the American Society of Hematology as well as the International Society of Hemostasis and Thrombosis, both of which are published online. And a lot of individual institutions are developing their own protocols for how to manage anticoagulation across the board in COVID-19 infection. And I think you need to think about that in the context of sickle disease, like you would in any other
disease. That makes sense. And we'll try to make sure that we post the links available to where this talk is posted so that they're accessible to everyone after.
Mm-hmm.
Tassos Cumberless at Children's National Medical Center in Washington, D.C., and also Natalie Shiloh at the University of Connecticut, pediatricians, were saying anecdotally they haven't had a lot of admissions for pediatric cases. So I would ask, the registry data that you presented, how many children's centers does that include? And is there outreach to try to understand what are pediatric centers seeing for sickle cell admissions?
So I don't know the exact breakdown of pediatric centers that are included in the registry. However, I do know there are several pediatric centers that are part of the registry data, and you'll see there are some pediatric data both from our center as well as others that are there. I would agree with both Tassos and Natalie that in the pediatric age group, it does seem like the risk of hospitalization rate of hospitalization is quite low. And that's what we've observed across many centers. We have had one pediatric patient who's been admitted, and she's a 18-year-old, so sort of an adult. And so, I think that from what we've seen, this seems to be a more significant disease in adults.
That's fair. And again, that's what we see in the general population.
Mm-hmm.
So one question I have from Hans Ackerman in the National Institute of Allergy and Infectious Disease in Bethesda is that we've read a lot about ACE2 receptors for SARS-CoV-2 and losartan angiotensin receptor blockers. A lot of our sickle cell patients are on angiotensin receptor blockers for proteinuria, for example. Can you talk about any discussions that you've had about whether or not those medications should be stopped? It sounds like the overall guidance is to continue what people have been prescribed since we don't have more data, but how has that come up in your discussions?
So the Sickle Cell Disease Association group has taken this on, as you would guess, as many of our patients are on both ACE inhibitors or ARBs for treatment of proteinuria particularly, but also for treatment of hypertension. And we felt as a group that the data for stopping these medications was not strong enough to recommend it. So we are recommending continuing these medications. We also took on the issue of nonsteroidal anti-inflammatory drugs because many of our patients are also on those medications for treatment of pain. Many individual practitioners are stopping the use of NSAIDs upon admission to the hospital for COVID-19. However, this is not a universal recommendation, but it is something to consider stopping patients that are getting admitted.
And that leads us to the whole idea of there are many other medications that people are talking about using that are really experimental therapies. So Mark Lagwin from the University of Pittsburgh wanted to ask, what is your take on whether we should use experimental therapies, grasping for something when we're trying to treat our patients?
I think this is a much more universal question that goes beyond sickle cell disease and really sort of speaks to the entire COVID-19 pandemic. And I think that many of us in the field are very leery about the use of experimental therapies in these patients.
For example, hydroxychloroquine.
Yes. For example, hydroxychloroquine, or even tocilizumab, which was used in my patient as well as in the case report that I presented as an IL-6 for IL-6 blockade. I think that as a group, we do not feel comfortable recommending any of these therapies for treatment for patients with sickle cell disease infected with COVID-19. However, we would advocate for the inclusion of patients with sickle cell disease in the upcoming and ongoing clinical trials of these agents,
right,
conducted across the country, and we would advocate that sickle cell disease patients should not be excluded from clinical trials based on their underlying sickle cell disease.
That makes sense. That's a really good approach, I think.
Mm-hmm.
So, do you have any other closing thoughts that you want to share with people? Any particularly difficult cases that you've had, or anything else that we should look out for in terms of registry data coming on, or how people could get involved with the registry?
So that's a really good. Those are all really good questions. I think that we continue to need to gather more data on what's going on with our patients living with sickle cell disease who are infected with COVID-19. And so I would encourage participation with the registry data. These are de-identified data that are generally, for most IRBs, this is an exempt, IRB exempt protocol. Depending on your institution, your IRB will likely require you to submit a proposal, but it is usually considered to be exempt human subjects research. I can provide the link of the site, and so that you can find out more about it for people that are interested. I think the other piece that I definitely want to make people aware of is that those of us in the sickle cell community are advocating for blood donations. There is a national blood shortage that has resulted from all of the stay-at-home orders and social isolating that is going on, and this significantly impacts the sickle cell disease community, and as well as other communities requiring transfusion, which would just be the critical care community in general. And so I didn't want to be remiss with not mentioning the need for blood donations at this time. I think what we've seen, and this is sort of classic for patients with sickle cell disease, is that there are always going to be occasional patients who present very strangely in the setting of COVID-19.
Right. It's hard to put together. It's a really great talk, and I think everyone appreciates being able to see some of that initial registry data. We know that's just the start, but I think it helps people connect with what is being seen, even if it's sort of just the tip of the iceberg. So again, thank you everyone for joining us. And please feel free to share the link to this talk. It should be widely available. Thank you.